The medical world has kind of largely shied away from discussing this, but I think what's important to do in our brief time today is to kind of get into what we see in the medical literature, what is recognized as pituitary-related emotional symptomology, and then observe quantifiable treatment interventions. Before we get started, I just want to let you know I have no conflict of interest or funding as relates to this talk. So can everyone in the room, can we all do an activity together? Even those work in AV, let's all do this together, all right? I want us all to go back in time, if you can, to when you knew nothing about pituitary disease. You were just a mere lay person navigating the medical waters. So, like Back to the Future. So can everyone go back in time with me for a little bit? Right, a little less gray hair, a little less wrinkles. Everyone with me? Okay. Because what I'm going to do now is I'm going to read you a retrospective case report. These are doctor's notations and then personal notations by the patient. And this was actually presented at a PNA conference about 13 years ago. And what we're going to do from a non-clinical perspective, we're all going to play Dr. House. Everyone knows that show, right? We are going to attempt to diagnose this patient based on the clues we have, if, dun dun dun, there's a diagnosis to be had at all. You ready to play? All right. And I guarantee you it's not Mrs. Blue in the library with the candlestick, but it might be the surgeon in the OR with the knife, but we shall see. All right, so from this patient case report, October 5th, 1996, 11:43 p.m., subject is placed in observation following body cavity search, concern expressed reconcealing a razor or perhaps other sharp object. Where could this patient possibly be? A psych ward? In jail? Any other ideas? Pituitary conference? No? All right, so, okay. Mother reports that over the past 12 weeks, there's been noticeable weight gain in her child, menarche at age 9, currently not menstruating. Pediatrician notes that erratic menstrual cycles are not uncommon in adolescents. Mother reported similar symptoms at age 12. Any idea what she could have, if anything? I do this with my students. I don't have to call on anybody. Mr. Martino? Depression, that's a possibility. What else? Guess. Yeah?
You said weight gain?
Mm-hmm. But again, we're talking about that we're a lay audience, right? And we're doing this as if we have no medical background that we have today.
How old was it?
12. 12 years old. Hormonal imbalance? I'm sorry, I couldn't hear you. Yes, that's a possibility too. It's a possibility. Again, it could be in the library of the knife though, so we shall see. Intake team consult, October 6, 96, consensus in diagnosis of anxiety disorder coupled with extreme depressive episode, MDD, and suicidal ideation. October 8th, additional quasi-diagnosis, school phobia, situational difficulties adjusting to new middle school. Patient placed on Zoloft after 4 weeks, no noted improvement. Possibility of environmental factors. Patient is currently in an outpatient day program for adolescents, feels out of place. Others in the program have drug addiction and or juvenile defenders. Throughout interview, patient is observed perspiring. January 1997, Zoloft, lack of success. Patient now prescribed Prozac. No noted improvement after 6 weeks. There's a possibility patient is not adhering to the medication regimen. Clue, right? Mother is instructed to observe daughter taking pills. Noted acne, referral made to dermatologist. March 1997, patient switches physician team. Continued concern about evading taking of medication. Effects are now prescribed at pediatrician well visit. Again, noting patient is 12 years old. Weight gain noted. Patient encouraged to, quote, exercise and to focus on hobbies. Okay. Sound familiar? Again, what could she have? What?
Emotional disturbance.
She could have emotional disturbance. She could have needing a hobby, like this clinician suggests. Ooh, that's interesting. Nutritional deficiencies, right? Because they do manifest in behavior as well. So May 5th, 97, despite age, hypothesis now of mild bipolar disorder, or type 2 is what we would say nowadays. Patient's parents report mood swings, no immediate risk to self, but mother reports that she has locked all medicine cabinets to prevent possibility of self-harming behavior. Patient tapered off Effexor, placed on Paxil. A pediatrician memo, quote, this may be just a rough patch. May 15, 97, patient accompanies grandmother to appointment, symptoms shared with doctor. Grandmother queries if there is somehow some medical causality for symptoms of loss of menstruation. Pregnancy test ordered, it's a possibility. Pregnancy test negative. Notation of issues related to perceived normal, because what is normal to begin with, right, in age group and early onset of menses. Grade 8, spent with interpersonal and mood difficulties, monitoring by parents, no changes in symptomology, continued weight gain, attributed to the taking of medication. Grandmother again brings patient to personal GYN visit. May 20th, 1998, follow-up pediatric appointment, diagnosis given. All right, now as a room, we're done with Back to the Future. What does the patient have? Right. Story we know all too well. In a personal essay that was given at a PNA conference about 13 years ago, the girl said, quote, "I'm told I have a brain tumor on my pituitary gland, a prolactinoma. My mom began to wail, but me, I'm happy, I'm thrilled, I couldn't feel any better. I was depressed and anxious and sick and weak, and now I know why." Something I'm sure many people in the room can relate to. And again, it's a story that we hear time and time again. And I think the diagnostic difficulties in this case are only confounded by the difficulties inherent in treating the emerging adult population, right? Adolescent, young adult. But there's something about that news about causality, no matter what the age. That moment when you're sitting in the doctor's office chair and you finally have a diagnosis to accompany your seemingly unrelated symptoms, it can actually be euphoric in a sense, right? There's almost a sense of relief there, answers, really a validation. And there's this thought that there's a light at the end of the tunnel. Careful what you wish for, right? Because surgery and radiation and medication can often alleviate many of the physical symptoms that beset patients. But as you all know, the road has more bumps. There is often psychiatric symptomology that either persists or occurs after that initial treatment intervention, broadly defined. And in a recent volume by our PNA board physicians, it was noted that residual psychiatric symptoms may persist after quote-unquote successful treatment. One could ask then, and I ask this question of my students, is treatment even successful then if one of your biggest symptoms was psychiatric in nature and now suffering is no better or is perhaps worse? Indeed, as this volume from our board clinicians indicate, many studies demonstrate that pituitary patients experience increased psychiatric morbidity as well as impaired quality of life. As such, it's really crucial that we understand the observed psychological impact, both pre and post-treatment, broadly defined. We don't have the exact knowledge to understand why hormones affect behavior or why hormones affect different people in different ways, but we do have quantifiable reported evidence of psychiatric disturbance, both peri and post-initial treatment intervention. And perhaps what's most important, and perhaps the reason why you're here today, is figuring out how to live your life to the fullest, and how to diminish these perceived quality of life and psychosocial hurdles presented to you. So in discussing psychosocial aspects of pituitary disease, some would argue that it's important to somehow distinguish between psychological symptomology that's the result of the pituitary tumor or the pituitary endocrine dysfunction. Others want to understand, what is the psychiatric sequelae of pituitary disease? People want to know the exact cause of their psychiatric symptoms, and that's completely understandable. But the answer is we don't know causality. But we do understand is that there's a real problem here and it deserves attention. That's kind of where we need to focus our efforts. And we need to validate the reported patient's psychological experience, and I think that that's what we're doing today. So Dr. Nicoletta Sonnino and Dr. Giovanni Fava, they were examining this topic in the late 90s, and they made a really interesting point even then. They said not enough attention is paid to the psychosocial aspects of endocrine disease, the role of life stress in the pathogenesis of some of these conditions, their association with affective disorders, the presence of residual symptoms after adequate treatment, and how patients have difficulties coping with endocrine illness and its often severe psychiatric consequences. Now, when I share the report about this girl that I read to you, when I do this with my classes, students often suggest many of the same things that you all did. But a few weeks ago when I was lecturing my students, something interesting happened. One student kind of popped up and said, Professor, I don't think it was the tumor. I think she was so frustrated that nobody was listening to her, and that's why we saw the manifest of these particular symptoms. It wasn't the tumor per se, but the diagnostic process that was making her psychologically ill. Thought that was interesting, right? And another said, maybe something was going on at home. Maybe there was some kind of stress going on at home that caused this particular problem to happen. So maybe it's not this pituitary tumor, maybe it's something else. And it's important for us to understand the tumor is not necessarily to blame for everything. Psychological issues can happen independent of the tumor, but also as a result. And there's kind of this chicken and egg that we go back and forth with. Many people see this difficulty. The biological changes from the tumor as the sole culprit, right, for psychological disturbance. But it's indeed possible to have either pre-existing or post-treatment, post-surgery, post-medication. You could still have mental illness independent of the disease. And then once you have the diagnosis, there's the emotional impact of having to live with the knowledge that your life is now somehow different. You might face invasive treatment protocols and subsequent quality of life outcome. And depending upon one's orientation to the mental health field, a clinician might say the problem is just between the ears and it's in the head, kind of this Thomas Szazian take, if you will, on mental health symptomology. Though as we all know, the issues are much deeper, right? And they're perhaps more reminiscent of Canguilhem's discussion of normal and pathological and the impact of ill body on perceived ill mind, despite this lack of full understanding about the mechanism of action, how exactly these tumors biologically affect the brain. But patients are more than the tumor and the diagnosis. There's no doubt in my mind that even if the girl we just heard about did not have a pituitary tumor, there's still the possibility that she could have developed depression or an eating disorder or mood swings, right? Like I said before, it's easy to blame the tumor for everything. And we have seen this positive correlation between incidence of tumor and affect on behavior since Harvey Cushing published on this subject in 1913. And then over the course of the past century, we've seen forays into analyzing women who have both a tumor and a case of hysteria, a comorbidity at least, of alterations in mood about 50 years ago, and a bevy of studies over the past 30 years. I argue, instead of playing chicken and egg and trying to get to the root cause of the psychiatric symptoms that we see in pituitary patients post-diagnosis, not necessarily post-treatment, we should instead pay attention to the observable symptoms, regardless of causality, and identify what are quantifiable treatment interventions that we can take to improve the patient experience. You can think about how hormones affect people in different ways in the regular population, non-pituitary, PMS versus PMDD, for example. What happens in one person that makes that hormonal experience somehow different? But remember, no matter the cause, you or your family members or for the clinicians in the room, your patients, you deserve to feel better. You deserve to have a life worth living. So what I'm going to do now, I'm going to go through what we observe in the various patient populations, and then we're going to get into some aspects of treatment. So to expand a bit on the work of psychologist Valerie Golden, it's important to note that all patients, broadly defined, have been noted at least to have unipolar depression, mixed depressive and anxiety symptoms as frequent comorbidities. And we'll return to depression shortly. But we see anxiety, both generalized anxiety disorder, but also panic disorder. And while these symptoms can affect all pituitary patients, we see higher levels of quote-unquote pathological anxiety in patients with prolactinoma. I know there were a few questions in the last session about prolactinomas. Also, there's noted irritability. There's legitimate fear of not knowing what's going on in one's body, fear of post-treatment recurrence, things like that. And we need to understand, however, that because anxiety, this particular anxiety, is associated with a medical illness related to hormone levels, this can be viewed as either a coincidental occurrence or a causal occurrence. Does that make sense? Right? So what is causing this? And that affects actually the psychological diagnostic process and the subsequent treatment process. So that's why it's really important to kind of recognize these issues early on. We also see extreme weight loss or weight gain because of the influx of hormones, but then we also see observable behaviors that are seen in patients with eating disorders. And thus, we give out diagnoses of anorexia nervosa, bulimia, etc. And that's actually kind of interesting. Out of depression and anxiety, we see in all patient populations that many patients turn to manipulation of eating behaviors in an attempt to quell such feelings. There was one patient whom I met at a pituitary conference, a PNA conference about, maybe about 10 years ago. She had acromegaly, and she also had diagnosed anorexia nervosa. And I'll never forget this. She looked at me and she said, "Jess, I can't control what's going on in my body, but I can control what I'm putting in my mouth." Now, I don't suggest anyone adopt what she was thinking, but it goes to show the desperation, but then what people will do in an attempt to handle what's going on. There's that saying, drastic times call for drastic measures. So it's certainly understandable when you're talking about this patient population to see why people will manipulate eating behaviors to such an extent, given what the tumor has done. We see this also especially in Cushing's patients who will have unequal fat distribution and an onset of weight gain as well. We also see issues of apathy, lowered libido, and depression is the one that comes up most frequently with all pituitary patients. And this brings to mind, this is so telling. This brings to mind a recent study, and this was noted. Though the majority of pituitary adenomas are benign, the physical, emotional, and cognitive changes that these patients experience on a daily basis might as well be malignant. And that's certainly very telling. We also see mood swings, someone being emotionally labile across the board. Recent studies have shown that in cases of Cushing's disease and syndrome, right, a patient might present manic initially or hypermania in the earliest stages. But not a lot is known about this. The analyses that have been done have been retrospective in nature. Some 30 years ago, it was thought that patients were being treated for not their Cushing's disease, but hypothyroidism. The influx of thyroxine thus put them into what was thought to be a manic phase. So again, not really too conclusive. And again, though, these intense mood shifts, understandably, interferes with one's inability to have successful interpersonal effectiveness. Couple this with the lonely, I'm the only one going through this type experience of many pituitary patients, and it comes as no surprise that both loneliness and embarrassment as a result of how you're acting because you are so compromised, how these result from behaviors acted upon as a result of emotion dysregulation, and how it's both the result but also the byproduct of this disease. It's rather complex. We also see anger, rage, or out-of-control response to stimulus. This is seen in all across the board. It is sometimes noted higher in patients with acromegaly. Understandably, it's also seen in people with elevated testosterone levels, also people with issues with IGF-1. One of our members was saying to me about all the rage he experienced pre-diagnosis, a result of testosterone imbalance and perhaps overall frustration, and the cost that it was taking to his marriage. Now, we don't have any clinical findings to support this, but there's a lot of anecdotal evidence to suggest that rates of divorce between pituitary patients and their spouses is pretty high. I will say there is evidence in the medical literature with regards to chronic disease and rates of divorce as well, so one can maybe make that positive correlation as well. We also see neurocognitive impairment, memory, attention, executive functioning, social withdrawal, issues of apathy or motivational difficulties. And we see these in non-functioning or non-secreting tumors as well. And I always put non-functioning in air quotes because it's there and it's still doing something, right? And now post-initial treatment intervention, we may also see this too, but it's coupled with anxiety as well. We're going to come back to this in a minute. This is a street sign, if anyone here is from New York City, on 72nd Street between Amsterdam and Columbus. It's been there for years, but it's always struck a chord. When you think about Horowitz and Wakefield, for those of you familiar with his work, their arguments about sadness and grief, and the point at which this rises to the level of pathology, right? What's normal anxiety or what's normal sadness, and what's pathological anxiety, and not pathological sadness, but depression, we do see that there's certainly anger that's involved, there's bargaining, there's depression, there's a loss over the feeling of one's prior health and emotional stability. Now, people don't necessarily go through all of, let's say, Kubler-Ross's stages of grief, or they don't go through it all at once or necessarily all in order. But the medical literature about pituitary patients has indeed cited the fact that a lot of patients do go through the stages of grief after their initial diagnosis, and then sometimes after treatment as well. Now, interestingly, again, this is seen across the board with all pituitary patients. Is it all right if I move on from this, or are folks still reading this? I can move on? All right. Okay. I don't know if you can see this one too well, but come back to the second. The thesis of a uniform psychopathology due to influence of elevated hormone levels, it can't always be confirmed. However, what we do see is a high incidence of emotional disturbance in these patients. So it's clear that there's a connection, the exact mechanism of which we're relatively unaware. So while hormone levels certainly affect the patient, it would be misleading to think that all psychiatric symptoms disappear following that initial treatment intervention. In fact, new symptoms may emerge, and there are both biological reasons and there are behavioral reasons as well. Certainly, we see this when a patient is prescribed a medication post-surgery. Looking at this patient's experience on Dostinex or cabergoline, for example, she's reporting that it's making her depressed. Other people report anxiety occurring after they take the drug that's supposed to help them treat the tumor, and the tumor also causes emotional side effects. Anyone a little confused? Because I am, right? So I just think it's important to look at this particular patient experience. We've also issued with testosterone and aggression. So can drugs intended to treat the tumor actually cause further psychological distress? And these are things that you need to think about. How is the treatment actually treating me? Now, there are a bevy of symptoms also related to people who have diabetes insipidus as well. Now, from a behavioral standpoint, which is my orientation to this, it's easy to see why mental illness either continues or how new symptoms emerge post-surgery. Pardon the language. There's no doubt as well that the diagnostic process itself wreaks emotional havoc, and it takes significant time to recover from it. There's something to be said about that gut-wrenching process, knowing something is wrong with you, only receiving invalidation, but then getting someone to believe you, and then finding out your exact diagnosis. It can actually be what we consider in the literature to be a traumatizing experience to some, and to others a contributing factor in psychopathology. So after this whirlwind of diagnosis and surgery and recovery, there were observable behaviors resulting from this traumatic experience. Now, we don't have enough medical literature on this, so it's an area of research interest. We need to look at also rates of adherence to protocols in pituitary patients. Sometimes patients are so fed up by all they've been through and the invalidation and the continuing illness that they'll often skip follow-up appointments. Or if not seeing the pituitary specialist like they're supposed to, they'll skip out on the regular primary care visits. They might even skip out on the dentist. You start to see other behaviors slip up as a result of the emotional response to prevalence of the tumor. Others are so have distrust of the medical establishment, as you see from this gentleman's post here. And sometimes there are surgical complications. Sometimes people's entire pituitary gland has to be removed. And needless to say, there's going to be significant cognitive impairment, perhaps definitive psychopathology as a result. There might be damage to the hypothalamus causing hyperphagia. And with these factors, there's increased anxiety, understandably so, about being able to work, about job loss, about being able to sustain relationships. And for those whose appearance has radically altered, and that's a personal evaluation of self, but if your appearance is radically altered, we see people who don't want to go out in public anymore out of fear of being mocked. We see increased issues of anxiety as well. And I show you this picture not to be funny. Half of the people in the picture I'm about to show you are pituitary patients. This was the legacy of pituitary patients roughly a century ago. So it's easy to see why pituitary patients feel such a sense of invalidation with the medical establishment and how they feel that they've been made some sort of sideshow. But where do we go from here? Right, getting help, kind of just to start. For most patients, the process of recovery, it goes beyond that OR recovery room. Given rates of recurrence, which we learned about this morning, or inability to fully extract the tumor, which we also learned about, pituitary adenomas can actually turn into a lifelong chronic illness, and perhaps our orientation needs to change a little bit. And understand this is more than a pituitary tumor. This is now going to be a new process that we're going through, or it's going to be a new stage of life. And And there's a really high prevalence of both depression and a severe sense of helplessness. So to quote Dr. Law and Dr. Izzat and Dr. Asa's edited volume, which recently came out, this depression that patients feel may in turn decrease their ability to adjust to these new chronic symptoms, to adhere to treatment, to feel satisfied with the care that they receive, to enjoy and live life to the fullest. All of these are somehow impacted by the incidence of the pituitary tumor. And while pituitary tumors may initially manifest and subsequently present as psychiatric disturbance, think back to that girl's story at the beginning. And what are some observable steps that we could take to, in Marsha Linehan's words, she's the founder of dialectical behavioral therapy, what can we do to make a life worth living? So one, getting help. It's important to be screened, I'm just going to back this for a second, to be screened periodically for signs of depression or anxiety. And in cases of recurrence, these are the first symptoms. It's not necessarily amenorrhea or galactorrhea or any of the bevy of physical symptoms. Sometimes it's depression and anxiety, and that's the first clue that, hey, the tumor's back, or it's recurring, or it's growing. Two, it's really important to develop a relationship with a psychiatrist, psychologist, and neuroendocrinologist who are willing to work together. You need your three musketeers, and here's why. If the tumor and its effects are properly managed, but yet psychiatric symptoms persist, people will often turn to psychotropic medication and those types of interventions. But it's crucial that your psychiatrist talks with your neuroendocrinologist, your psychologist, and maybe even your neurosurgeon. The reason, as we've all joked, it's because everything's in our heads. Some psychotropic medications actually affect pituitary tumors, and there's the possibility of making them grow. In the case of the little girl, for example, she was given Effexor that only served to raise her levels of prolactin, and she already had a prolactin-secreting tumor. Can you imagine what that's doing to her? Right, it's only making it grow. In the past 5 years, we have seen, anyone seen a commercial on TV for Abilify? Right? We've seen an increase in the use of second-generation antipsychotics or atypical antipsychotics for people with both depression and anxiety. Now, the change in mood is often more profound. It affects you that much faster, and they're generally prescribed as an adjuvant therapy to general classes of antidepressants. There's only one problem here, and I apologize that this is a little bit dark. I can make copies of the list of studies for you. What's underreported is that these second-generation antipsychotics, these atypical antipsychotics, actually can increase prolactin levels. So now, if the general adult population without a pituitary issue are experiencing amenorrhea, development of breast, galactorrhea, can you imagine what's going on in the pituitary patient? It might make them better in the short term, but worse longer term. So here's a list of studies, which again I could show you afterwards. Coming back to this earlier slide, it's important to have that frequent contact between your psychiatrist and neuroendocrinologist and psychologist because, as I said before, a lot of the drugs that you end up taking, and not the second-generation antipsychotics, but the drugs you actually take to treat the tumor actually have psychiatric sequelae themselves. And the treatment team needs to be aware of this. And this is serious stuff. I mean, I don't think it gets more serious than this wife who spoke about her husband attempting suicide. Now, many patients discuss an inability to function, an inability to regulate emotion, to control rage. However, patients can, with cognitive behavioral interventions and dialectical behavioral therapy, DBT, you can use these skills and really build a life worth living. There's kind of a paradigmatic shift that needs to take place, but targeted activities, mindfulness, and changes in behavioral practice can actually help the patient to more fully function. And in fact, there was a study done in 2005, memory serves, and what they found was that it wasn't the medication for depression that helped the patient, it was actually DBT interventions related to apathy, which actually improved patient experience. Now, patients who have comorbidities can participate in something called a DBT skills group. In addition to going to weekly kind of training seminars, and it's almost like a classroom type setting, you also participate in one-on-one therapy with a DBT or CBT, cognitive behavioral therapist, trained counselor. Now, this was a treatment model, just so you know, for your own edification, initially intended for borderline personality patients, people with suicidal ideation. However, recent studies demonstrate that for people with chronic illness, going through a cycle of DBT, dialectical behavioral therapy classes, and one-on-one treatment have better patient experience and outcome and adherence and rates of adherence to medication. So there is noted positive intervention here as well. There are other types of support groups as well. So let me just go to this next one here. Okay. It's helpful for patients to connect with one another. How many of you today met someone who, for the first time, another pituitary patient? Anyone have that experience? Yeah, it's kind of an amazing thing to know there's someone out there who knows exactly what you're going through. There are a lot of illness-centered support groups. Shara, you have a support group, right?
Yes, we do. I'll talk about that in the next.
Awesome. I wanted to make sure we got the plug in. Fantastic. Great. But here's the thing. Charmin's groups are wonderful. Sometimes they're few and far between, and they're tough to find. So what a lot of hospitals have, they have a lot of brain tumor-oriented support groups. They might be chronic illness-centered support groups. And also, there are networks out there for parents whose children are undergoing treatment, but also for spouses and other family members. So every member of the family is affected by the disorder, and there's help for everybody involved. It's important, I emphasize support groups, but I think it's really important to try to find the right one, right? You got to try on a couple pairs of shoes before you pick the right one. You got to just try them on for size. And I got to say this, with the proliferation of social media these days, everyone takes to Facebook, right? And there are these patient-owned and operated, if you will, support groups based on Facebook. And we all know they're like message boards, right? I'm not even going to ask, but I know all of us have at some point maybe posted in one of these groups, right? But they're more like message boards, and the answers are not always immediate. People vent, they talk about what they're feeling, they ask medical questions of other patients. Now, these are great, but I would not rely on these as your sole support or source of information. And I know that that seems like very silly advice and seems like common knowledge. But we've all been sitting at the computer late at night, not feeling well, and we automatically, the first thing we do is Google our symptoms, right? I've had students come in and they say, I have a brain tumor, and it's right here. I Googled it last night. I said, what are your symptoms? Well, I was swimming yesterday. I said, you have swimmer's ear. Stop Googling everything, right? Stop going on Facebook and putting it in. And she was convinced until she went to the doctor and found out, yes, it was swimmer's ear. But seriously, if you go to these Facebook groups, you have to do so with caution. You really don't know who's at the other end of that screen. You don't know if you're getting the patient's full story. Sometimes on Facebook, people will omit certain identifying details or parts of their story to protect their confidentiality. But all of you know that it was one little clue, like a detective, that helped you solve your medical mystery. So that's another reason why relying on these as sources of patient support, I'd be wary. Also, it can be a very draining experience to log on to Facebook and to see these posts coming at you. And there actually have been research over the past, I'd say 5 or 6 years now, pointing to the impact of social media on well-being. And it's shown that over time it can actually lower self-esteem in some people or perception of self-esteem. And if someone is depressed and they're seeing negative news all around them, it only serves to lower their mood. So if you're a pituitary patient battling depression already, is that really the best environment for you to be in? Probably not. Probably time to log off. Now, many of the patient testimonials that you saw behind me today come from Facebook. And I brought the slides with me so that you could see the patient experience. You've seen frustration, angst, pain, confusion, exasperation, but help is out there. And again, it's if you look for the best type of help there is, and that's why, from a psychological perspective, I recommend the DBT model in this patient subset. But if you can't find that live in-person group, then at least join a professionally moderated group via Skype. Again, few and far between because of licensing issues. But even though it's not Facebook, it's not ideal, it's better than nothing. I just wanted to show you this. This was posted a month or so ago by a patient in the UK talking about how she put her life together. I think it's really important. The first step here is validation. It's validating the patient experience. Many pituitary patients find themselves battling psychiatric sequelae resulting from the pituitary tumors, symptoms that quote-unquote aren't my fault, but it's important to radically accept the situation, to seek help. Remember, there are physiological changes that occur in the non-pituitary patient, right, which result in mental illness. So it's not about blame, it's not about regret, it's about being aware, validating the experience, and then moving forward. Now, today's short talk only scratches on the surface of the complexities of the pituitary patient. But if there's one message I'd like everyone to take away from today, it's that with proper support, intervention, advocacy for yourself and for others, and knowledge, you can live a happy, fulfilling life. I'm just going to go back real fast if I can to this slide. That's where you can find a DBT-oriented health professional. But again, you can live a happy, fulfilling life, and you could say who you are without necessarily having to always self-define as pituitary patient. I should know that 12-year-old girl who I was telling you about in the beginning, that was me. All right? Thank you, guys.